So we are back with our clinical case. I'm going to pause the video right now so you can see. So this patient came to see me because she hated her two front teeth on the lower arch. She obviously has some restorations done on the top that, although may look good, sort of are canted, and you can see how her lower teeth are actually completely worn down. She needs a reconstruction of her vertical and fixing all of the flare teeth, but essentially she only wants to address the lower. Basically, under those two teeth in the front, there's a dental implant that was placed right down the middle of the teeth. And if you actually look closely, which is actually very interesting, it looks like she has 7 teeth between 22 and 27, where she's really only supposed to have 6 teeth. So the reason is that her teeth are so flared and they're so wide, they weren't able to actually make it aesthetic, so they thought maybe they'll do 2 teeth, which is a total disaster. So our treatment plan, you'll see throughout the whole case, is to try and fix that as best as possible and give her the best aesthetic result that's possible within the limitations that she's giving us. So back, we're gonna start the video. This is where she's at. Right then and there, we're prepping 22 and 27 to give her some canine guidance when she protrudes to the right and to the left in lateral movement, so that she doesn't break her lower anterior restoration, specifically the implant. Specifically these type of cases that they're very shallow, even though they're held in by a multi-unit, sometimes you get screw loosening because there's a lot of lateral movement. So we want to make sure that when she goes to the right and to the left, they're not crashing into each other. So we're going to build up the canines. Quite simply, we do a nice little prep. On the lingual, we stay supragingival, so it's easier to clean. Now we're opening up the access hole of this restoration. Luckily, they put some Teflon tape, so we don't got to fight. Put in a 1.27 driver, come out backwards, and boom, you'll see I'll take out the restoration. And you can see obviously there's a massive defect and very hard to clean. I'm now using the Salvin kit to remove the implant. I knew this implant would come right out. I'm going to have to trephine it out, and boom, it screwed out, no problem. Now we're going to take out the hopeless teeth. This one has a failing root canal on it. The one next to it has a tremendous amount of bone loss from the implant, and then that one is basically cracked into the nerve. You can see that buildup of the bonding with periodontal issues, and we're going to sacrifice that tooth for the good of her case. Okay, we just split mid-crestally. We don't do any vertical releasings at all whatsoever. We release a little bit on the lingual to help us in the future when we're going to need to put all of this back together. Very careful there. We start to curette all of the restorations, all of the infections out. And then we go and we drill. It's super important to understand the anatomy of her arch. You can see as I drill, it looks like I'm a little bit buckled because that's the way her anterior mandible is. If I went straight out and up and down, I'd either perf out on the buccal or perf out on the lingual. I'm using 2.0 Densa burrs. In reverse, this is a gorgeous 3.3 Megagen Blue Diamond implant that went in with over 15 Newton centimeters of torque. And then same thing there. Boom, one's a 11.5, one's a 13 millimeter, 3.3. It's got a nice 2.4 tip, which is awesome. Torque it back into position. I'm going to use a taller multi-unit on the back one there because I know I have good soft tissues, so I'll have no issue in terms of bringing everything back to there. I go ahead and I screw in a straight multi-unit. I now release the tissue on the buccal because I'm going to have to graft that huge defect because she didn't like that dip. So we're going to try and build this as best as we possibly can. I place my JA scan bodies on top. And if you look closely, we have on the mesial of 27, you can see there's a little bit of bone, so I'm going to have a hard time placing the multi-unit, which we realized after, the scan body, which we realized after was an issue. Hence, we had to retake the impression and change the multi-unit. But regardless, cortical cancel is bone, nice and thick, gonna hang out for about 3 to 4 months. We release within the inside a split thickness to be able to reposition the tissue up. Luckily, the previous dentist cut out her frenum, so we don't need to do that to make sure that it doesn't pull. We dry, then we put a thick piece of mucograft on top. because we're not going to do full closure. We want it to granulate in and give us some new tissue. And we're going to do interrupted sutures with 4-0 PGA. I love this suture. It hangs out about 3 to 4 weeks. Super easy to stitch with. And we're just going to put the papilla back to where we think they should end up. Tuck in the mucograft. It's bleeding. I like that when it's bleeding. That means my graft is going to be fully hydrated with cells, and it's going to start to heal nicely. Very careful when we suture with no tension, but to make sure that it's not going to dehisce over time. Bring that papilla over. Tuck in the mucograft. We have a little bit of attached tissue there. Yes, I could have done a free gingival graft, but one miracle at a time. Maybe after she heals, if I need to do that, I will go after that. She was very, very scared of the treatment. She's a wonderful lady, but less is usually better. I get it. You can do a lot of fun dentistry, but sometimes we just have to see what the patient allows us to do to be able to get the best result within the confines. Personally, I wouldn't want a chunk cut out of my palate. I'd love to see how this just heals in, especially with the mucograft. And a cortical cancellous, it heals really, really well. Clean out, make sure nothing's fallen out. Dry, dry, dry. Now we're gonna diode the tissue because I want to cheat by bringing 22 and 27 a little bit deeper buccal. I like to make, especially in these minimal prep type of restorations, I didn't prep more than 0.5 millimeter. I like to sort of create a feather edge margin because I can then feather the restoration when we do that. Try not to move so much bone. Just bring everything over to where it needs to be. All right, no water because I don't want my graft to disappear. Bring down the margin, feather, feather, feather. Feather all around. Scan the soft tissue and the prep. JA scan body's placed. Make sure that flat side is always exposed so that you can pick it up and the library can align perfectly. I'm going to pause this right here. We go ahead and we printed the restorations in Flexera, and this is like a B1 bleach mix. Obviously it doesn't match, but I like to just print it this way and then color it in the mouth. If you look closely at the multi-units, the scan bodies are in a different position because after I designed the case, I realized that after retracting the restorations, even with a 30-degree angle correction that the Powerball screw allows me to do, it wasn't exactly where I wanted it to be. I was able to correct it, but I had to flare the teeth a little bit, which I didn't want. So I decided also that I would switch both multi-units to 17-degree 2.5s. This also, if you look closely, gives me more space for my tissue to come in, and that's on the buccal. So it allows more room for the tissue to grow in as opposed to the restoration pushing up against there and the multi-unit. So it brings everything in and allows you to do that. So that's that. We're gonna deliver the restorations with Tempon Clear. They're made in high occlusion because I wanted to adjust them after. Now I'm trying to stain it the best that I possibly can to last for about 2 weeks. She's like an A3. I don't know if you can tell so well in the color, but I add different types of body and colors to try and get it to the best that I possibly can be within the confines of what I'm able to do. Add white for the effect. Take out the multi-units. You can see there the scan bodies, those are angled. Drop in the restoration Powerball screws, 2.0. Other one, 2.0. I go to 10 on a printed restoration, and you can see that I'm having a little bit of a hard time, and the reason is the contact was too tight on one side, so it wasn't fully seated. So all I had to do was adjust the contact, and then boom, it went in perfectly. because remember I cemented 22 and 27 first. Anyhow, that's the initial design. We've already redone the design and she has a new prototype printed. We're gonna go and open up the embrasures, just why not, to make it a little bit fun. Under there's ovate pontics to try and push on the tissue and maintain where it's supposed to be. And now we start to color it as best as we can. I don't know, I like to color in the mouth, especially for something temporary, because I can just really see what I like, what I don't like, cut off what I don't like, see how it is within the shadows of the mouth. Check the bite. Obviously, they're high on the canines, so we're going to start adjusting that. Just because the upper was so canted, I didn't want to give her a roller coaster on the lower. I'm trying to set the implants out of occlusion, so that she's not hitting them at all. And she's riding on the canines mostly. We're getting there. It's my new favorite thing. A little gel on the inside. Cure it. Check the bite. Patient's good. That's really it. This is a super fun case. These cases are sometimes even harder than full arches because you're trying to fit something perfect or imperfect into imperfect. It's a little bit difficult, and you need to be ready for this, schedule the time to be able to do it correctly. And be aware of how much you're retracting the teeth. Especially in a case where the teeth are super flared, that means that the mandible is very flared. So even though you have to follow the anatomy of the root, you need to be able to correct the angle after the fact, so prosthetically it's okay. You know, it's not like in a full arch case where you flatten everything and you create the angle that you want. This is you're following the roots that are there right now. So that's very important. And most importantly, when you do these cases, under drill and understand not the size of the implant. So the size of the implant was a 3.3, but the tip of the implant's a 2.4, which is why I only drilled to a 2mm drill, and then the top was in a socket. If I would have drilled to a 3.3, we wouldn't have had any stability, and then we'd have to go to a larger implant and then possibly break the buccal plate. So always keep in mind, specifically with tapered implants, know all the dimensions from the top all the way to the bottom, how much it tapers, and you will always get stability and be able to immediately load these cases. I hope you enjoyed it. Make sure to subscribe and follow me, and looking forward to your comments.